And then you're going to be able to.
Oh, sorry, Ken, what was that?
And then you'll be able to just flip it back to sharing my screen.
No, you'll have to
I
click
have to
the share screen button again. Yeah.
Okay.
But while we have everyone starting to filter in now, I'll just give the introductions. So welcome, everyone. Thank you for joining us for our 18th Gateway College Lecture Series. We really appreciate your support and the interest in contributing to the knowledge economy. My name is Jay McFarland, and I am on the board of directors at Gateway and also the research chair in rural nutrition and exercise. Gateway has the world headquarters in Goderich, Ontario, and is the only independent rural research institute in Canada and governed by a community-based volunteer board. We aim to advance the rural health teaching and research across Huron, Perth, Grey, and Bruce counties. Our mission is to improve the health and quality of life for rural residents through research, education, and communication. So beginning in February of 21, Gateway launched this lecture series with social isolation being at the top of mind as the COVID restrictions continue to heighten. There is no better time to launch this initiative. And so through these lecture series, our hope is to cultivate and culture rural health knowledge and innovation. Leading discussion today is Dr. Ken Milne. Dr. Milne is Gateway's research chair of rural medicine. He's also a physician at Strathroy Middlesex General Hospital, has a lot of experience at the South Huron Hospital, and has been doing medical research for 39 years, publishing a variety of topics. He's also an associate professor at the Schulich School of Medicine Dentistry at Western, and is passionate about skepticism and critical thinking. He is the creator of the knowledge translation project, the Skeptics Guide to Emergency Medicine. So thank you so much, Ken, for joining us. And thank you to our panelists as well. Jimmy Trio, the president and CEO of the hospitals in Goderich and Exeter. Kristen Watt, a pharmacist extraordinaire in Southampton. And Kevin Talbot, a realtor in Goderich, bringing a patient perspective today. So I'll hand it over to you, Ken, and thank you for leading discussion.
Thank you very much. I'm going to take a couple of seconds here to share my screen, and so people can see my slides. And there you go. Can I get a nod from a panel member that my slides are up? Yay. Well, I really appreciate the opportunity that Gateway is giving me to speak again. I really have enjoyed these lecture series. Last year, I gave a talk called Health Information, Who and What to Trust. So this year, I wanted to talk about postal code medicine. And if I'm going to talk about postal code medicine, I've got to go back to the Canadian Health Act. And I'm going to put one of our panelists on the spot here. Jimmy, you ready for this?
I'll do my best.
There are five parts to the Canadian Health Act. Now, I think it would be a little much to expect the CEO of Alexandra Marine and General Hospital to come up with all five, right? You know, I don't know how many cups of coffee you've had this morning, but at least, can you give me one of the five principles?
One of them would be accessibility.
That's great. See, you got this kick started already. It's an active panel. So accessibility, yes, access to care is fundamental. And it's one of the five pillars of the Canadian Health Act. The other part is that it's supposed to be administered publicly. So it's a publicly administered healthcare system. The third thing is universality. So it's supposed to apply to everyone. Everyone should get access and have access and accessibility to healthcare. A fourth principle is comprehensiveness. And so that means it should be womb to tomb, cradle to grave, beginning to end of life. And then the fifth and final thing, and this gets back to postal code medicine, portability. It should travel with you. Healthcare should travel with the individual. So it doesn't matter where you are in Canada, you should get access, whether you're urban or rural. And I would suggest that the Canadian Health Act tries to ensure equity, that all Canadians, no matter where they live, have access to appropriate and timely healthcare. Perhaps that's an idealistic goal, but those who know me know that I'm an idealist. And I would posit that we should be striving to achieve this, even if we don't reach it. It's like that shining city on the hill that we should all be trying to get to, and that is equity. So if I'm going to talk about equity, I need a slide that looks like this that explains the difference between equality and equity. And the reality is, in our society, we have haves and have nots. And those that have more than they could ever possibly need. And we have others in our society who, well, I wouldn't say live, but survive at a standard of care that we would consider inhumane. And equality means that everyone gets the same help. Yet because there is baseline differences on where people start on this spectrum of have and have nots, it doesn't result in equity. So equity means everyone gets the help and support they need to, quote unquote, succeed. And that means some people won't need any help at all to succeed, while others may require quite a bit of support. Now, again, being that optimist, being that idealist, liberation, that view that we eliminate all barriers so everyone can reach their potential and feel fully engaged in society, and that this society is inclusive. Now, so how do we get to this ideal society? I would suggest we follow the philosophy put forth by John Rawls. And he called this the veil of ignorance. And it suggests we should imagine that we're sitting behind a veil of ignorance. So you can't know which part of society, which class you are in, where on that spectrum of have and have nots you will fit. And without that knowledge of your status, that's when we can make the most just determinations of how society should operate. So decisions about equity to access to healthcare should be made not knowing, hey, am I living in a large urban center, or am I in a rural or remote community? And that's how we should make decisions about equitable access to healthcare, following this veil of ignorance. Now, equitable access to healthcare, this is not a new concept. I mean, you can go back 2 decades and find the federal minister of health, Alan Rock, who said, geography cannot be an excuse for inequity. And yet here we are with a panel of experts sitting around 20 years later with me giving a lecture on the problems of postal code medicine. That your postal code will be an important factor that determines whether or not you have access to appropriate and timely health care. So this aspiration of building a better society with access to appropriate health care goes back to the beginning of socialized medicine in Canada over 50 years ago. Yes, I'm bringing out black and white photos of Tommy Douglas, who said, "Courage, my friend, 'tis not too late to build a better world." Well, I'm going to say on this lecture, courage, my friends, 'tis not too late for rural people to get the health care they deserve and expect. But we do have a problem. Yes, we have a problem. And I would suggest that rural emergency departments can be viewed as the canary in the coal mine. There have been so many local, rural ER temporary closures. This includes Clinton. We've seen it in Seaforth, Wingham, Listowel, not Godrich, I might add. Durham, Chesley is now closed for 2 months. Simcoe just announced a closure, and many others. This is one of my mentors. This is Dr. Alan Drummond. He's a rural doctor from Perth, Ontario, and he's been advocating for rural healthcare for decades. In fact, he's such an advocate that they've named an award after him from the Canadian Association of Emergency Physicians, or CAPE, and it's called the Al Drummond Award. And it's given each year to the physician who's gone above and beyond in advocating for patient care. Because we in the emergency department, we're the light in the house of medicine that's always on for anyone, for anything, at any time. And so I've learned a lot from Alan Drummond, and I'm going to try to channel his enthusiasm and commitment to rural healthcare in the rest of this lecture. Now, some people, they've blamed COVID for these problems that we're seeing in rural healthcare. Yes, we've always had issues with access in rural areas due to lack of healthcare workers, and this includes not just physicians, but also other professionals like nurses, respiratory therapists, dietitians, nutritionists, nurse practitioners, pharmacists, and many others. Now, COVID didn't create the problem, but it certainly has exposed the weaknesses, the frailties of rural healthcare. And it was another mentor of mine who came out of Goderich, Dr. Jim Rourke, who ended up being the Dean of Medicine at Memorial University in Newfoundland. And he years ago said, you know, when the city lawns are brown, oh, the rural areas are on fire, people. So we've seen multiple newspaper reports talking about the problems in urban emergency departments. You may have seen some of these headlines like, sick kid says ER wait times up to 12 hours. We got one recently from the London Health Science Centre in London, Ontario, warning patients that they were getting to the 20-hour mark for wait times, 20 hours. They were saying, hey, bring some bottled water, bring snacks, bring a power charger for your phone. I mean, yes, this is horrible. This is absolutely unacceptable that people have to wait so long for access to emergency care. However, Chesley is going to be closed for 2 months. So people will be waiting there for 1,344 hours to get access to emergency care in their own community. So while I sympathize and I empathize with the urban situation, there are communities out there that their local hospital is closed for emergencies and will be closed for days, weeks, or even months. And, you know, rural medicine, it's been described as the ologists. I mean, rural medicine, it is often run by a few individuals providing many different services compared to urban care where you have a lot of different individuals. So rural physicians are often the cardiologist, the respirologist, the gynecologist, the pediatrologist, the orthopathologist. They're all of it. That's all you're going to get. That one generalist that can provide all of those services to a certain level. And if one of those individuals gets sick with COVID, moves, retires, you lose so much of the system. And again, I'll go back to Jim Rourke from Goderich, who said, if you want healthcare workers in rural areas, you need to grow them locally. And that means you recruit at an early stage when they're in primary school, encouraging them. When you have gateway projects where they run summer camps to encourage high school students to experience what it's like and have some experts come in and share their joy of rural medicine with high school students. And then you follow them along in their career, whether it's in their undergraduate university career. You have them come back and have placements in their rural communities. When they're in their residency training positions as physicians, you have them do their training in the rural communities. And that way you can recruit and retain those valuable resources. Now let's take a little look at equity for rural Canadians here, just looking at a population map of Canada. Roughly about 38 million people live in Canada, and about 1 in 5 are considered rural, so 19%. And look at that population density. It's about 1 per 4 kilometers squared. But most of it lines that US border. But then we have these vast areas, the farther north you go, of very few people living in rural and sometimes remote communities. So I'm going to use an example to point out postal code medicine and the decisions we need to face as society. These are not decisions I make as a physician. These are decisions society needs to make. And so I pulled out the example of stroke care. Now we have this very powerful treatment for treating stroke. Stroke is a devastating condition which the blood supply to part of the brain is blocked in the vast majority of stroke cases. Most of them are due to blockages. And we have this very powerful treatment called endovascular therapy. This is sort of like where in heart attacks, they can go in and suck out the clot from the part of the heart in the artery and restore blood flow to the heart. Well, they're doing the same thing now in people's brains. And they only do it at very select centers. And one of the centers is the London Health Science Centre in London, Ontario. And if a person has a large blood vessel occlusion, an LVO, a big blood vessel in their brain that's been blocked, and if it has certain characteristics and it happens within a certain time frame, you can suck that clot out. And these people who have had a devastating injury, it can reverse that. However, very few people qualify for this. Very few. And because rural areas are so vast, it often requires the use of helicopters. So these are called helicopter emergency medicine services, or HEMS, to fly these people from rural areas to places like the London Health Science Centre who can do these treatments. And it sounds great, doesn't it? Wow, we can have this technology. You've got these crews of pilots and co-pilots and advanced care paramedics and landing pads at these various hospitals, and you can fly these people around to get them this care. Okay, but at what cost? And the question would be, would these millions of dollars be better spent in beefing up rural hospitals like Goderich and other community hospitals, giving them funding for stroke rehabilitation? Because the evidence that supports stroke rehabilitation is very strong. It's a very effective therapy. So, should we take the millions of dollars and fly a few people around, or should we address all the stroke patients and spend those same millions of dollars at the local rural center and do stroke rehab? Again, I don't have the answers. I'm just throwing this out as a suggestion. But you can look a little bit further and say, what about Maslow's hierarchy of needs? If you remember years ago, if you took this in sociology or psychology, that we have some basic needs: food, water, shelter, clothing. That's the basic needs we have. And yet higher up on that is advanced healthcare. And so should we be spending all of this money on one level of healthcare when we could maybe just be providing, I don't know, clean drinking water? And so how about looking at it from a social determinants of health and primary stroke prevention? Emergency medicine is often standing at the bottom of a cliff waiting for people to fall over, and then everybody scrambles around and tries to put Humpty Dumpty back together again. Maybe it would be better if we could promote primary prevention and keep people healthy. In other words, don't be downstream waiting for these people and these bodies to float by. Why aren't we upstream preventing these people from falling in the river in the first place? Controlling their blood pressure, smoking cessation, diabetes management. Or how about affordable housing, good jobs, access to appropriate education? And this gets me back to water. Did you know that there's approximately 60 First Nation communities on long-term water advisory? They can't even drink their own water when it comes out of the tap. Now, would it be better to spend all of this money that is being put into this advanced stroke care? Would be better to make sure that First Nations communities have, I don't know, clean drinking water, and start with that. Maybe if you're living in a large urban center and you're an Amazon Prime member and you've got a smartwatch, and all of a sudden you're having a stroke and your accelerometer and your watch says, uh-oh, this person has fallen, but you're an Amazon Prime member. So this drone flies in, drops a portable MRI on your head, scans your brain, and then this robot comes out and does this endovascular therapy. Ah! Can you imagine that in rural areas if they dispatch some of these drones flying around in these rural areas? I'm concerned they might get shot down. But anyways, I'm not trying to create a false dichotomy, between you have to have clean drinking water or you can only have endovascular advanced therapy. That would be a false dichotomy. You can have both. You can do both. Society can decide, I want everyone to have access to clean drinking water. This is an equity issue. And I also want everyone, no matter where they have a stroke, to have the potential to have this advanced care, this endovascular therapy. But I would suggest that we don't do an endovascular therapy as the first thing without addressing the clean water, and that we can do both at the same time, but let's make sure that everyone has clean water. Well, I've talked about the problem for a little bit, and I want to make sure I'm saving time for the panel members to come on and give their expertise in this area. Somebody is an administrator, somebody is a fellow healthcare professional, and also somebody to advocate for patients. Somebody like Kevin Talbot, who can come in and say, you know what, I live and work in these communities. I have a business in this community. I want to thrive in this community. I raised my children in this community. This is important to me. I'm also a patient and person in this community. So it's so important to have that on the panel. But we've talked about access to care in rural areas, and I've given you a concrete example of some choices we might have to make. Time to talk about some potential solutions. First of all, I would suggest perhaps converting some rural emergency departments to urgent care centers that are open during daytime hours. This can give comprehensive emergency-like care during the busiest part of the days, whatever that busiest part of the day is for that local community. But you can't just do that. You can't just say, okay, we'll cover most of the people for most of the time, but then after hours, yeah, whatever. After hours, you need to beef up your emergency medical service system. You need to make sure that you have enough crews on the road to transfer those people to the larger hubs. And then you also have to resource the larger hubs. This is what we're seeing right now when smaller hospitals are closing. It's not that they add additional treatment rooms. They don't upstaff nurses. They don't upstaff lab technicians. They don't upstaff diagnostic imaging hours to these other hospitals because the smaller hospitals around them have closed. The volume just goes up. Demand doesn't disappear when you close a small rural hospital. People still require healthcare. But if they're going to be transferred to the larger centers, those larger centers, they need the resources to handle that increased volume. And then we need to think the full cycle of the contact in the emergency services. So if that person has the problem, they call 911, you've got enough EMS trucks to deliver those patients to the places that are open after hours when you rarely have those life-threatening or limb-threatening emergencies to the larger community hospitals. How do you get those patients home after they've been treated through these rural areas? We have a system right now in our local area called Voya Go, and it transports non-emergent patient, but it turns out that sometimes it's Voya No, and they can't transfer those patients in a timely fashion. And then you have this patient, and it is often an elderly patient, stranded in an urban center, blocking access to care for other patients, and their loved ones can't come and visit them. And so we need to think that full cycle. So if we're going to move on to an urgent care center setup, make sure that we have enough EMS vehicles and make sure we have transportation issues addressed and make sure that those larger centers are resourced to handle the increased volume. And those resources, at least the human resources, may come from the smaller places because we don't have to have 2 emergency room nurses on at night in the small center or an emergency physician on night at that center. And maybe they can micro allocate those scarce resources. And then I'm going to finish with one of the most important suggestions, and that would be having amazing rural healthcare professionals. If you can find more like Kristen Watt, because she is a superstar pharmacist, But she's often having to work with one hand tied behind her back and not properly resourced and given the funding and the resources to give the care to her local rural population. And this results in moral injury. You want to help them, but you're going to lose money even if you provide care to them. It is actually, you're still running a business, and yet we have this resource. We have these other healthcare professionals. Community pharmacists are amazing individuals that help me almost on every single shift I have. And yet we're underutilizing them and tying their hands behind their back so they can't be working to their full scope of practice. Now, she's on the panel. I'm not an expert. I'm not going to mansplain her job to her. All I'm saying is, an outside individual looking in, can we have more Kristen Watts, please? And I look forward to hearing what she says. So to finish, access to healthcare should not be determined by your postal code. Rural people expect and deserve appropriate and timely care. Thank you. And now we will go to the panel session. As soon as Jay McFarland jumps back on, I've ended my sharing of my screen, so we should be able to have everybody there. Jay, do you want to go? Do you want to go and lead this panel discussion that we have? Because I've done enough talking.
Sure. I mean, never get tired of hearing your voice, Ken. I think you bring up some interesting perspectives in a very interesting way. So I like to first go around the table and hear about from your own unique careers and experiences and the parts of society that you resemble as panelists today. Tell us your perspectives on the challenges of rural healthcare, and then we'll get into the solutions hopefully in a little bit. Also, if you're an attendee watching today, feel free to pop your question in the chat box there. So maybe Jimmy, let's start with you. You're first on my screen. What do you see as some of the challenges, or anything from Dr. Milne's presentation you'd like to address? It's sort of your floor to talk about challenges.
Yes, thank you so much. And Ken touched on a numerous set of items that we can all talk about, and from our own experiences. I think two of the most important ones that Ken talked about is really skill set, making sure that we have the right skills across our organizations to make sure that we are able to provide that timely care, whether it be nurse practitioners or primary care or specialists. And I think the other thing that Ken really touched upon that I think is really important as well is resources, right? And he talked about, if there's EDs that are closed, what are we doing with those resources at those closed EDs? Those should be moved around, because Ken is right. It's not postal code medicine. It's where you can go to get that care when you need it. At that moment in time, right? So really spreading those resources around and making sure that the organizations that are open have the right resources to care. And I think the other thing that I find that's really important in today's times is really about compassion, and making sure you have compassion for the patient, making sure you have compassion for your colleagues, and also having compassion for yourself, because we know that healthcare work is really, really tough, and it's only going to get tougher as time moves on, and the challenges that come with it. So making sure that we have compassion all around, I think, is important as well. And I think those three things really, when I think about what Ken has said, really resonates with what we've been doing here at the hospital.
Great. Thanks, Jimmy. Yeah, I agree. I mean, compassion is the key to delivering excellent healthcare. And I think that in a rural setting, I think it's so much easier to have that compassionate perspective, because these are people you often recognize from being around town. We all seem to know each other. Kristen, I'd like to hear from you about your perspective on the challenges of rural healthcare as Ken was describing it.
Sure. Thanks, Ken. That was fantastic. I think from my perspective, one of the biggest challenges is access to primary care. We have proper primary care. Our patients don't need to seek urgent and emergency care as often. We know that with COVID-19, patients' access to their primary care providers was decreased. We also know that it's very likely we're going to see late-stage cancers, COPD exacerbations, diabetes that's poorly controlled, and all of these are going to end up in our urgent and emergent care situations. And so we really need to focus on growing primary care in our communities and understanding how to access care within our communities. I had a patient recently indicate that they were planning to go to Emerge to sit there for travel medicines, despite having a family physician. So we really need to promote proper access to the care that is out there, and focus our projects, our future, and what the revamp of our healthcare system looks like into primary care. I'm actually on a working group with Ontario Health as part of a rural response pandemic recovery working group, and a lot of the suggestions that we've made have not necessarily been possible to implement, because we're hearing that, no, that's not something that we do. I think we need to really look at the entire system and be willing to make really big changes at this time, that we're really at a precipice of change in healthcare, and understand how care is delivered, especially in these rural areas, so that people can access the care and we don't have 20-hour wait times in the cities or closed ERs in our smaller communities, because part of this closure is due to burnout, due to illness, due to shortages in health human resources. If we don't have overusage of emergency departments instead of primary care, we may not see that burnout, and we may be able to service the population that truly does need to be serviced in those emergency care departments. So I really think we need to look really hard at primary care delivery, whether it be from physicians, or obviously I'm going to advocate for pharmacists, because there are primary care clinics in other provinces that are pharmacist led. There's a ton of med management that can be done by pharmacists instead of needing to go to Emerge for a diabetic med change, or for even just things as simple as a UTI. So we really need to be looking at our entire system, and if we can get our primary care supported, paid for, staffed, we may see less need in our emergency departments.
Right. Yeah. Thank you for that, Kristen. Just a quick follow-up question for you. In that last thing you're talking about, the roles, responsibilities, and of different professions in the healthcare system. Can people call telehealth for a prescription refill? Is that an option?
No, that's not an option. Telehealth is staffed by nurses, and they advise patients generally of self-limiting management of symptoms, say fever or whatnot, and advise people to go to Emerge or follow-up care with their family physician if they feel uncomfortable managing it through telehealth. So unfortunately, at this time, it's not a resource that may direct people away from Emerge. There are some instances where for refills, patients can call their pharmacies. It's not a funded program that I can prescribe. So unfortunately, we have to charge patients because it's not something that we're paid to do. So that causes barriers as well. Generally speaking, in my pharmacy, no patient is going to go without, and those who can't afford, then I do it out of my pocket, or I rob Peter to pay Paul and find other funding and other means to do such things. But no, there's not a way for a patient to call telehealth and get a repeat. And there's good reason for that. They usually need a follow-up. They need lab access. They need other things. They need symptom monitoring. So we can't just issue prescriptions that way.
Right. Okay. That makes a lot of sense. Thanks for clearing that up. I'd like to hear from Kevin. Kevin, your perspective as a patient and a member of our rural community, what do you see as some of the greatest challenges for our healthcare system right now?
Again, access locally. I've been fortunate raising my family in Goddard that we've had good access, but lately seeing on the news and social media, the closures around the area makes me nervous, skeptical, just for people living in those communities, knowing that it actually could happen locally in my community. As a realtor, usually when somebody's coming out of the area to see Goddard, one of the places I drive them by is our medical clinic and hospital. And that seems to be a priority for a lot of people moving into the area, especially people that are retired. They're concerned, of what the future holds for them in terms of healthcare. You know, families with even with young children want to make sure that we have, you know, local healthcare. So as I see the closures on the news and on social media, it's scary as a you know a citizen, and I worry too about communities that have closures, how it's going to affect future growth for them. And you want to see these communities vibrant because I guess as they grow, you know, the population, you know, may indicate that they may need more servicing type of things. So these communities could start to see some depopulations where people are going to go where medical services are available.
Right. You bring up some good points there, Kevin. And I think we've experienced a lot of you know, the unique challenges of living in a rural environment. Before we get into solutions, I'd like to hear from around the table now about you know, as a board member at Gateway Center of Excellence in Rural Health, one of the common criticisms we hear from our urban counterparts is that while access to healthcare, that's one of the trade-offs or one of the decisions you choose to make by living in a rural area, is you may not have that timely access to healthcare. Now we could that may be valid, but I'd like to hear from the perspectives around the table. Is living in a rural area, do you think that's one of the choices we make when we live in a rural area, that we should have a different access to healthcare? Jimmy, let's start with you.
I would say absolutely not. I think through the pandemic, I think we've realized that, you know, you can work from anywhere. So working from anywhere, you know, really also brings along with it the expectation that you'll be able to get all these services wherever you go as well, right? So I would disagree with that. You know, you choose to live there, and then so you choose to also take the challenges that come with it. But I think, you know, as we kind of talked about it earlier, and Ken talked about it, it's really the appropriate resources that are put across the continuum for healthcare, and we have to focus on the downstream and the upstream of healthcare as well, right? And as a hospital CEO, I would always say, you know, it's one of the last places a patient wants to be is in the hospital, right? If you can get yourself out of the hospital, the quicker you're out of there, the better it is for the patient. And so, you know, Ken touched on it a little bit in his talk by focusing on resources for health promotion and health prevention. I think that's kind of the first step. And I know we're getting into solutions there, but you know, that I think that's important as well. And then once you kind of have that piece, and if you have to go to the hospital, you know, you're in and out as quickly as you can. But then on the upstream piece, you need to have those home care services for people that you know are discharged, right? And we know that patients want to remain longer in their homes, and so we have to make sure that there's a concerted effort to kind of focus on putting resources in home and community care as well, in order to kind of you know, really make that continuum of care work.
Good. And we're starting to get into solutions now. Maybe we should shift our conversation to solutions now, or Kristen or Kevin, do you have any comments on the should rural just accept that healthcare is something we can only access in urban centers?
We shouldn't. I mean, people can't necessarily afford to live in urban centers. So the reality is then, therefore, now they're losing services due to their own income or their own circumstances or other social determinants of health. And we need to find ways to provide health across the province. No, I don't think that we need to have major trauma centers in every location, but we need to have access to those. And that's the key.
Okay, well, I would love to get into some of the solutions.
Could I just say something there with regards to that, Jay?
Sure, go ahead, Kevin or Ken.
You know, it's re-looking at the whole model of how we provide this fundamental service of access to healthcare. And, you know, when Kevin was talking about businesses and seniors and families, when we look at education, when a new family moves to town, they go to that school. and that school is resourced to have enough teachers, and they have very specific rules and regulations with the number of, students per teacher. And believe me, I'm not a teacher, so I'm not trying to teacher-splain. I'm just talking as a parent. But if you move to a small town, how come we can't have healthcare like that? Why is it that when you move to a community and you move to that area, you have to sit on a waiting list indefinitely often to get a physician? Why isn't it that you aren't assigned into this group of physicians, this group of healthcare workers? It doesn't just have to be physicians, nurse practitioners, pharmacists, other individuals, but to that group clinic. And you're assigned that, and that group clinic is resourced for that population, rather than this system of, well, you move to town and if you don't know anybody, you're not getting a doctor. And that is the inequity I think it makes me feel very uncomfortable. And we don't do that with, oh, you moved to town. Well, we've already got, I don't know what the teacher to kid ratio is, because my children are beyond that stage, but we have 25 or 30 students. So if we have one more student, sorry, you're on a waiting list, you don't get to go to school. That's what we're telling people who have ongoing chronic conditions like diabetes, COPD, hypertension. Well, so what? Just go to the emerge. If something comes up like a heart attack, we need to. Anyways, I would love to be a fly on that wall that Kristen's working on, to hear some of those solutions that they're working on, because we really need to think that the system ain't working, and little band-aids ain't going to fix it.
Well, I've seen on the topic of solutions, I've seen a few questions in our chat box there, specifically about emergency rooms and non-emergencies. And there are really not enough walk-in clinics, no walk-in clinics in Huron, as far as I know. So what are the options then for someone who has a non-emergency care problem? What should we do in a rural area when there are no walk-in clinics? What's the best course of action here? And the bigger question, what's the best solution for this problem?
I can tell you what my patients are doing right now. So in our I'm in Southampton, Ontario, so a very small part of Bruce County. And there's a whole bunch of Band-Aid solutions. The Grey Bruce Hospital system has a virtual care physician, but this requires patients to have internet and to have technology at home and to have prowess to be able to access that, which a number of my older patients can't do. Then there are other options, including waiting for your family doctor, going to emerge, or they come and see me and we try to troubleshoot. I'm really fortunate that in my small town, I have a great relationship with all of the physicians and have ways of getting a hold of people who may or may not be working. That also speaks to the burnout that all of the family physicians are experiencing, because it's their off clinic day and I'm contacting them and they're kind about it and they're accepting that patients need that care. So they're providing that care in a different and remote manner. It's not perfect, but it's the only solutions that we have right now. I agree with what Ken put forth earlier about looking at some of these smaller and more rural areas as urgent care. We have no walk-ins whatsoever in Bruce County, and we have one, I think, in Grey County, and that's up in Owen Sound. So the access is really, really low for people. We also need to look at the number. I'm going to go back to primary care because I still think that's the answer. The number of primary care spots that we have, the residency programs that are in this area to build up our primary care access. Because when a physician who is paid a fee for service needs to roster so many patients that they can't necessarily see their patients in a timely fashion, that's concerning. Maybe we need to look at how we're paying physicians, and nobody ever wants to talk about money because physicians are paid too much, and they are embarrassed to bring it up because they're often told, you make enough, you've got to make it work, but that's not necessarily the case. So we really need to look at there's not just one solution. It has to be holistic, because our physicians who are already here are burning out and they're leaving, and our patients continue to not have access in our area, and some end up going without. And of course, obviously, I'm going to point out, if pharmacists could prescribe, then that would take a burden off, but we need to have a framework in place for that, because while we'll be able to prescribe starting in January for certain things, we still have no idea how much that we're going to get paid for it.
Great. Thanks, Kristen.
I'm happy to talk money. just, because if it's the right thing to do, I mean, I think you figure out what services you're going to provide, and you start with that. You start with the needs, and then you go back to the budget and the money and figure out how you're going to deliver it. You don't start with, we have X number of dollars, and so we're going to ration care, and we're going to be able to provide this service. I think you say, we have this amount of service that we need to provide to patients and people to keep them healthy, and then figure out how we're going to pay for it as a society, as a community.
Oh, that's a very good point, Ken. I'd love to hear from the patient perspective. Kevin, what do you see as some of the possible solutions we could investigate or look into as we try to build our way out of this pandemic and address these problems in our healthcare system?
Well, I think too, in terms of like level of care, like you said, like Kirsten had said, somebody that needs a refill or something, instead of having to go to their doctor or wherever, having maybe more walk-in clinics, and maybe right from the top, addressing it from a funding perspective, like Ken said, finding out what each individual community needs and requires, and go from there. But closing hospitals and for certain days and times is definitely, especially when you're sick, is it's added stress.
Yeah, it's added stress, definitely. I noticed sorry, my screen seems to be flickering here, guys. Sorry about distraction. But I see in our chat box that we do have a walk-in clinic in Huron County. There is one in Exeter. So thank you for pointing that out, Ken.
I didn't want to advertise that too broadly because I didn't want everybody showing up at that clinic. So, but we do, yes. Ken is correct.
Right. Okay. One of the programs that Gateway runs is a long-term solution to our healthcare issues, and that is training our own. That's something that you mentioned there, Ken. Gateway has been very involved in training local students who are interested in a career in healthcare. Since we've been operating Gateway for about 14 years now, we're starting to see some of the fruits of that early labor come back, because it takes a long time to train someone for a career in healthcare. So we have started to see some of those first students through Gateway come back as physicians, physiotherapists, nutritionists, pharmacists. There's a couple of dentists in there too. So we are seeing that program start to take hold. Now, we do have at Gateway a 1-week summer camp that's hosted by medical students, the Discovery Healthcare Camp. It's directed at local high school students who are interested in a career in health, but aren't really sure how to go about it, what the right path is, and what the options are. So it's a 1-week camp that's run in July, and I have every indicator that it's going to be running again this next July, and that's a long-term solution, though. Training our own. So we're definitely looking for more of the short-term solutions. I saw a question in the chat box here about pharmacists prescribing for ear infections or some of the UTI. Maybe Kristen, would you like to talk about some of the things that pharmacists can do?
Sure. So right now in Ontario, pharmacists can manage your medications in terms of ensuring that the medications that you receive are the proper drug dose, timing, etc. If you're on 3 or more medications, there is a program for pharmacists to review your medications at no cost to you. It's funded through the provincial government, and we can manage a patient's medications. We do a ton of this in my pharmacy, everything from COPD management, diabetes management. I have a patient tomorrow who has cancer and is having difficulty breathing. Not urgent, Ken, don't worry. But just those kinds of conversations that they want to have with their pharmacist. We also do a ton of patient consultations prior to appointments to ensure that patients are armed with selecting a medication that may be appropriate for them given their current med regimen. A number of patients see many physicians, emerge, family doctors, specialists, palliative care doctors, and oftentimes their pharmacist is the only person or place that is consistent for them. So making sure that you have that relationship with your pharmacist. we've positioned ourselves here in Southampton as a pseudo primary care location. And what I mean by that is if you come to us, you are our patient. I can answer your questions. I can manage your medications, but we can't provide that same level of care for every patient who walks in the door. So we need to encourage patients to have that relationship with their pharmacist. If they go to any other pharmacy to get all of their prescription medications and today have decided that they need assistance with something, I will often refer them back to their regular pharmacy, because it's really important that patients are seeing consistent healthcare providers who have access to their information. So making that relationship with your pharmacist, and a pharmacist at a big box store is as trained as I am. They went to the same pharmacy schools. They have the same license. You can have that relationship with them. You just may not know it because you haven't had the opportunity to build that relationship. So do that, because starting in January, pharmacists in Ontario will be able to prescribe for certain things. I believe there's 7 or 8 conditions. They're called minor ailments, which if a patient's experiencing at the time may not be so minor to them, including things like UTI, where we can assess the patient for this and prescribe medications for them. It's much easier to prescribe for them if I know their medical history, but of course we're going to give as much care as we can to everybody in the community, but this is coming. Right now, we don't know how much or if we will be paid. That's concerning to us because we're not willing to offer 2-tier healthcare. Those who can afford this can come into the pharmacy same day and receive care, and those who can't need to go to Emerge and wait 20 hours, or they don't have an Emerge that's open, or for whatever reason, right? So we really need to understand that a lot of the things that we're talking about is provincially funded. So votes matter. Talking to your elected representatives really matter, because they're the ones who decide how much care I can provide to the community. If this is funded, I can hire more staff. I can bring in more people. I can run an appointment-based system that is only for minor ailments in our community. Ultimately, we would love to see pharmacists be autonomous prescribers. In Alberta, they are. You can walk into your pharmacy, we can take your blood pressure, we can prescribe you medication for your blood pressure, and in a perfect world, we could order labs and things like that. So in a perfect world, we get there with pharmacists, but we need funding in order to support it, because I will need extra staff to offer this because we're already busy as it is.
Right. Yeah, it's an interesting time to be a healthcare worker right now. It's being pulled in many directions. So yeah, the stress, just trying to be the best help and best patient advocate you can be. On that note, on the note of addressing patient advocacy, and directing people where to find answers, where should people call, or what when they have problems with system navigation? Like, is there a number people could call to get that help, to find out where can I go, where should I go? I'll open it up to the floor here.
I think this is where having a primary healthcare team, not a healthcare provider, not a healthcare individual, not a doctor, but having a team. And we should all consider ourselves on team patient. It starts with patient care, it ends with patient care. And the better we know the patient, the better care we can give as a team. And so it doesn't always have to be me. It doesn't always have to be Kristen. It doesn't always have to be another individual. It has to be someone who has access to the resources. So, one of the flaws is you call a service like telehealth and they don't know you, and they go through an algorithm, and it's somebody in a bunker call center somewhere, a professional, but they don't have that knowledge of who you are, right? And having a health team, a group of individuals that is helping you live your best life, your healthiest life, is so important. And it costs less money, to do that, because when they show up in the emergency department, we order more tests, we treat more often, we give out more antibiotics that are perhaps necessary. And so having a team of professionals on your team patient is so important. And I think that's how you navigate. And that's why I got back to using the school model. When you come to the community, you should be part of this group clinic, this community health center, this family health team, something like that, and that they know who you are and can provide you with the best care possible, with the best information. And I really think that's how you address navigating it. Right now, it's call a 1-800 number or whatever the number is. And I tell, I know not everybody ends up in the emergency department, but that's the final common denominator of the algorithm. At the end of the day, it's like, well, if you're concerned, or, they've got these, they err on the side of caution, which I understand why, is because they don't know the patient or the person. And so it's go to the emergency department. And we are not the best individuals to treat. We will treat anybody at any time for anything, but we have to recognize we're not the best person. Kristen is often the best person to figure out all those drug-to-drug interactions. I had a case the other day and I'm like typing in all these drugs and I'm like, oh, Kristen, why can't I have you sitting on my shoulder right now, helping me with this? This would have saved that person 3 to 4 hours of a wait in the emergency department to get someone like me trying to go, okay, oh, geez, okay, let's go through all these drug-to-drug interactions. That's not my lane.
One of the things that community pharmacy is facing right now is we're pretty much the only professional out there where if you call, you get us on the phone on that phone call. And we're trying to change that mentality a little bit because we can't function like that anymore. It's really too much for us. So if it's our patient and it requires intervention same day, they'll be booked for an appointment and I'll call them back when I can. That ensures at least I can have lunch or use the bathroom because I don't actually get to do that every day. But it's been really challenging and we are working hard to figure out how to make that happen in a community pharmacy to allow people to have continued access, but to allow my staff to also be humans because it's been really, really hard over the last couple of years. Because we're the place where there's always been a pharmacist behind a counter. You walk into a pharmacy and there's somebody there, and people have realized that more and more, which is great, but it can be challenging. The other thing I wanted to say is there's some advocacy happening against pharmacy or using our full potential. We went to school not to dispense. This isn't what I was trained to do. I have an entire technical team that takes care of it at my pharmacy, but Ken may have seen this on Twitter. We get attacked that we don't have the skills required to prescribe for our patients when that is in fact not true. That's the only thing I was trained to do. And we really need to understand that we all need to be playing nice in the sandbox because we do triage in community pharmacy, whether or not we're paid for it. Now, the number of people I've kept from Emerge because they have MSK or their knee has been painful for 4 weeks and they don't need to go to Emerge today, or sent to Emerge when they have severe full thickness burns of their finger, or in one patient, a patient was having an MI. And they were into the pharmacy because they had indigestion and I sent them to Emerge. So, I mean, we're already doing this. So we need to understand that we all need to work together because the ultimate goal is care for the patient. And we need not to be so protectionist about our particular skill set because there are lots of people who can do lots of things. We saw that with COVID vaccines. You walk into a COVID vaccine clinic, there are physicians, there are nurses, there are pharmacists. Every one of us can poke. So why don't we all use our skill set to the best of our ability and work towards getting the ultimate care for that particular patient and stop trying to block others as we advance together.
Great. Thank you, Kristen. And I think it's come time to wrap it up now. So I'm sure we could talk about this for a long lecture about the challenges and the possible solutions. But thank you so much to all of our panelists and for Ken for that presentation, creating this conversation around this topic and for all your insight. Thank you. If you are watching this from Hear and Tell and you would like to join us in the future, you can go to gatewayruralhealth.ca and register for future webinars. We also have recordings of all past webinars on our YouTube channel. So thank you also to our sponsors, DeJager, Town Square IBA, the Town of Goderich, Zayers and Goderich, Libro Credit Union, CIBC Wealth Management, McEwen and Fagan Insurance Brokers, and Hear and Tell for broadcasting today on Channel 1. I also understand that TCC and Hay might also be broadcasting today. So thank you to those for helping us spread the word. The Gateway is a nonprofit organization with charitable status, and we greatly appreciate any support we receive. So if you would like to make a donation, please head to our website, gatewayruralhealth.ca. Lastly, thank you again to all of the attendees joining us today. I love seeing the chat box being active, and we know we couldn't get to every single question today, but thank you for your participation. The next lecture series is on December, let me get the right date, the first Tuesday of the month, December 6th. at noon. Al Lozon will be talking about food insecurity for rural seniors. So feel free to pass along the information of this lecture series in your networks. And as Gateway, we promote the knowledge economy, reduce social isolation, and our mission is to improve the health and quality of life for all rural residents. So thank you everyone for participating, and the panelists and Ken, just great discussion. Thank you.